Hello everyone, today we are presenting our paper titled Individual Differences of Children with Autism in Robot-Assisted Autism Therapy. This work is done in collaboration with University Medical Center. Here let me introduce co-authors. Anara, Sandygulova, Aida, Amirova, Zhansaule, Telisheva, Aida, Zhanatkyzy, and Nazerke, Rakhymbayeva. First, let us present the context of autism in Kazakhstan. Autism is a relatively uncommon concept for the general public and research. Here, there is no reliable data on how many children live with ASD. The official statistics recorded more than 6,000 children. The number has increased more than 20 times for the past decade. The children receive treatment through the so-called psychological, medical, pedagogical commissions, which are common support mechanisms for all children with disabilities. The PMPCs are predominantly under-resourced to carry out autism diagnosis and therapy. However, huge support comes from grassroots level campaigns run by parents of children with ASD. Next, let's have a look at the background information where we draw on differences in symptoms and age. First, the severity of ASD differs significantly. Children live with either low-functioning or high-functioning ASD, ranging from mild to severe symptoms. Second, about 30% of children with ASD are either unable to develop speech or minimally verbal. Third, ADHD is one of the commonly diagnosed co-occurring conditions, and it is found in 30 to 80% of children with ASD, while ASD is diagnosed in 20 to 50% of people with ADHD. Finally, children in all the age groups may have better therapeutic outcomes compared to younger children. The more we learned about autism and its heterogeneous nature, the more we became confident that these children have varying differences and diverse needs. One size does not fit all. It is conventional yet overlooked wisdom. Our study aims to explicitly investigate diversity and presents how individual differences of children with ASD affect their social, emotional, and behavioral outcomes.
Therefore, we implemented 11 assessment metrics by adapting those used in previous studies as shown in the table. Two researchers coded a total of 46 hours of video with an agreement score reaching 82% on 20% of data. Overall, there were 11 measures as presented in the table that include engagement and valence ratings coded for each activity on a 5-point Likert scale. Engagement and eye gaze durations were coded and calculated relative to the overall duration of the session. For the affection metric, we looked for actions such as kissing, hugging, tender touching, scratching, petting, and other similar actions. For curiosity metric, we coded actions such as opening, rotating, touching body parts. For the aggression metric, we coded actions such as pushing, biting, hitting, pulling fingers. For the stereotyped behaviors metric, we coded actions such as hand flapping, hands biting, body rocking, toe walking, spinning objects, and others. We also calculated the frequency of pressing chest button, which we relate to the act of naughtiness. Finally, we counted the total number of smiles and spoken words in each session. This project is conducted in collaboration on the premises of Republican Children's Rehabilitation Center. This medical center provides a full-fledged integrated model of rehabilitation using innovative technologies. Children and their parents are hospitalized for 21 days to undergo a 3-week therapy. That includes traditional methods of autism therapy. On the first day of their stay, children have diagnostic assessments provided by the doctors, while therapists learn about each child's individual differences. Our study was approved by the Ethical Committee of the Nazarbayev University and the Republican Children's Rehabilitation Center. It was carried out between 2018 and 2019 and included 4 cohorts of children that adopted robot-assisted autism therapy within traditional autism therapy framework established in the rehabilitation center.
Each child attended a series of 15-minute sessions with an Amirova. The average amount of sessions the children attended were 7 sessions out of 10. Regarding the setup, all sessions took place in a small room without furniture. The child sat on the floor to maintain eye contact with the robot and its behaviors clearly. Also, we placed 2 recording cameras in the room. The first camera recorded child behaviors, while the second recorded the whole room. We developed various activities to be performed by the robot. Overall, we designed a total of 26 activities in both Kazakh and Russian languages. These activities received inspiration from applied behavior analysis principles and generally used various techniques enabling pro-social and emotional behaviors. Robot behaviors target children's emotional well-being, joint attention, imitation, tactile contact, concentration, and imagination skills. There were a total of 34 children, 2 girls and 32 boys, aged from 3 to 12 years old. Most children were nonverbal with an average ADOS-2 test score of 6.08. Tables that you see presents the participants' characteristics and information about the attended sessions. Here also you can see the breakdown. There were 10 children with a high functioning autism and 24 children with a low functioning form. 12 children had a co-occurring ADHD diagnosis, while 22 children were diagnosed with ASD only. 11 children had speech abilities and were labeled as verbal, while 23 children were characterized as non-verbal. We also divided children by their age into 3 groups.
We found a statistically significant interaction between the effects of ASD level, LFA versus HFA, and co-occurrence with ADHD, ASD only versus ASD and ADHD. The analysis showed that LFA children were smiling significantly less than HFA children when they had a co-occurring ADHD diagnosis, while there were no differences between children with LFA and HFA when they were diagnosed with ASD only, when they did not have a co-occurring ADHD. We also found a significant difference in the number of times children pressed the robot's chest button. Verbal HFA children pressed the button significantly more in comparison to verbal LFA children, while non-verbal children did not demonstrate significant differences between HFA and LFA groups. When comparing children's behavioral outcomes between first and last sessions, we found that verbal children decreased their curiosity, while non-verbal children had it decreased. Similarly, the aggression metric was also significantly different for verbal and non-verbal groups. Verbal groups' aggression metric was significantly decreased from the first to the last sessions, while the non-verbal group's aggression metric did not demonstrate significant changes. When we compared verbal and non-verbal groups individually, we found that verbal children pressed the robot's chest button, spent significantly more time being engaged, had higher scores of engagement and balance ratings, and spoke words 8 times more frequently in comparison to their non-verbal peers. Additionally, we found that verbal children aged 5 to 6 years old established significantly less eye contact compared to verbal children aged 7 to 12 years old. Additionally, we conducted a linear regression analysis, which established that age could statistically significantly predict engagement and balance ratings. Similarly, age could statistically predict eye gaze and engagement time. Additionally, we compared age groups as an individual factor using a one-way ANOVA. We found that a group with much younger children, ages 3 to 4 years old, in a darker blue color, showed more effective behaviors when compared to children in preschool, 5 to 6 years old, and primary school, 7 to 12 years old stages. For all other metrics, older children aged 7 to 12 years old had significantly higher ratings of engagement and balance ratings, longer engagement and eye gaze time, and the number of spoken words in comparison to other age groups. Qualitative observations were noted by one of the researchers with the following summary. For more detailed information, please refer to our paper.
Finally, here we present key takeaways emerging from our study. Verbal children were more positive and engaged, while their non-verbal peers were more curious between the first and the last session. For children with LFA and co-occurring ADHD, smiling as an affectionate behavior was less frequent than for those with HFA. Children with HFA and speech abilities were more likely to get to know the robot by pressing its chest button than their LFA peers. The older the children were, the higher the engagement scores were. Younger children were more affectionate, whereas much older children were more communicative, positive, and engaged with the robot than the other groups. Here is a list of references we used for these presentations. Thank you for your attention. We hope you enjoyed our presentation. Looking forward to hearing your questions, feedback, and suggestions.